You've done everything right, more fiber, more water, maybe even a stool softener from the pharmacy, and still stool gets stuck, and nothing seems to explain why. Today we're looking at 5 real, medically recognized causes behind this that almost nobody actually talks about. Most people already know the basic list. Not enough fiber, not enough water, sitting too much during the day, ignoring the urge to go when it first shows up. Those are real contributors, and they matter, but they are not the reason someone can be doing all of that correctly and still end up with stool that will not move. When impaction becomes recurring, when it happens even during weeks of good habits, the explanation is usually somewhere else entirely, in how the body is actually functioning behind the scenes. That is what the next 5 causes are about, and the first one starts with a muscle most people don't even realize they can misuse. It's called the puborectalis muscle, and it works together with the anal sphincter to control whether stool moves out or stays in. Under normal conditions, when it's time for a bowel movement, this muscle is supposed to relax, opening the pathway so stool can pass through smoothly. But in some people, the exact opposite happens. Instead of relaxing, the muscle tightens at precisely the wrong moment. Doctors call this pelvic floor dyssynergia, though it's sometimes described more simply as a coordination problem, because that's really what it is. The brain and the muscle are not communicating correctly during the process of elimination. Picture someone sitting down, feeling the urge, pushing normally, and yet the muscle responsible for opening the exit is doing the opposite of what it should. The result is stool that gets right to the edge and then stalls there, sometimes for days, regardless of how soft or well-formed it actually is. This is part of why the condition confuses so many people. It isn't about the stool itself being too hard or too dry. Even soft stool can become trapped if the muscle around the rectum won't cooperate. This cause is especially common in people who have spent years straining during bowel movements, whether from chronic constipation earlier in life, from habitually holding in the urge to go, or in some cases following childbirth, where the pelvic floor muscles can shift in how they respond to pressure. Over time, the muscle can essentially forget the correct pattern, tightening reflexively instead of releasing. It can also show up in people who deal with high stress or chronic tension, since the pelvic floor, like many muscles in the body, can hold tension without a person even being aware of it. What makes this cause particularly overlooked is that standard advice doesn't touch it at all. Someone can increase their fiber intake, drink more water, take a fiber supplement, and none of it will resolve the issue, because the problem was never about the consistency of the stool in the first place. It was about a muscle contracting when it should be relaxing. This is one of the main reasons people describe feeling like they are doing everything right and still getting stuck, because the advice they're following was designed for a completely different kind of problem. There is a way clinicians identify this, often through a test that measures muscle coordination during simulated bowel movements, and there are targeted approaches, like biofeedback training, that can help retrain the muscle to respond correctly again. But before any of that, the first step is simply knowing this mechanism exists, because a huge number of people dealing with recurring impaction have never even heard that their muscles, not their diet, could be the actual root of the problem. That's the first cause. The second one has less to do with muscles and more to do with something many people are taking every single day without realizing it's working against them. Before we get to the second cause, there's something bigger worth knowing. Researchers recently discovered why certain populations, despite eating far worse diets than most Americans, almost never deal with stuck, sluggish digestion in the first place. The answer had nothing to do with fiber or water. It came down to a hidden airborne trigger almost no one talks about, and a strange underwater ingredient discovered thousands of years ago that appears to work directly against it. There's a full breakdown of exactly how this connects to constipation and what to do about it in a video on screen right now. Just point your phone camera at the QR code to pull it up, or grab the link pinned in the comments below. Now back to the second hidden cause of impaction. The second cause is medication-induced, and it's surprisingly common because so many people take these drugs for completely unrelated reasons and never connect them to what's happening in the bathroom. opioid pain medications are probably the biggest offender. They don't just dull pain signals in the brain, they also bind to receptors throughout the digestive tract, slowing down the wave-like muscle contractions called peristalsis that normally push stool along. Without that motion, stool sits in the colon far longer than it should, losing moisture and becoming harder and harder to pass. By the time it reaches the rectum, it can be dense enough to essentially lodge in place. This is such a well-documented effect that it has its own medical term, opioid-induced constipation, and it can happen even with short-term use after surgery or an injury. But opioids are far from the only culprits. Certain antidepressants, particularly ones with anticholinergic properties, can slow gut motility in a similar way by interfering with the nerve signals that trigger contractions. Iron supplements, commonly prescribed for anemia, are notorious for causing hard, slow-moving stool. Some blood pressure medications, particularly calcium channel blockers, relax smooth muscle throughout the body, including the muscle lining the intestines, which can also slow things down considerably. Even certain antacids containing calcium or aluminum can have a similar hardening effect on stool over time. What makes this cause so easy to miss is timing. Someone might start a new medication for their blood pressure or their mood, and weeks later begin dealing with impaction without ever suspecting a connection because the medication seems completely unrelated to digestion. Doctors sometimes refer to this as a hidden side effect, precisely because it isn't listed as a headline warning the way drowsiness or nausea might be, even though for some people it becomes one of the most disruptive effects of all. The tricky part is that stopping or adjusting these medications isn't always simple, since many of them are treating serious conditions. But recognizing that a medication could be the root cause changes the entire approach. Instead of endlessly trying to fix the problem through diet alone, the conversation shifts toward whether the dosage, the timing, or the specific drug itself might need to be reevaluated, often alongside a preventive stool softening strategy from the very start of treatment. The third cause moves away from muscles and medications entirely and into the physical structure of the rectum itself, because sometimes the issue isn't behavior at all, it's anatomy. In some people, especially women who have gone through vaginal childbirth, a condition called a rectocele can develop. This happens when the thin wall of tissue separating the rectum from the vagina weakens and allows the rectum to bulge outward, creating a small pocket or pouch. When stool reaches this weakened area, instead of continuing in a straight path toward the exit, some of it can shift into the pouch and become trapped inside that pouch instead of continuing straight out. Even with soft, well-formed stool, this anatomical detour can cause stool to accumulate in the pouch rather than move forward normally. Over time, a person may feel like they haven't fully emptied their bowels because a portion of the stool is literally sitting in a pocket instead of exiting. This condition often goes undiagnosed for years because on the surface it looks exactly like ordinary constipation. Someone might increase fiber, drink more water, try every laxative available, and feel only partial relief because none of those approaches address a structural pouch. Diagnosis typically requires an actual physical exam or imaging, such as a defecography test, which allows a doctor to see the rectum in action during an attempted bowel movement. Once identified, treatment options range from simple manual techniques that some patients learn to relieve trapped stool, to physical therapy for the pelvic floor, to surgical repair in more significant cases. But the key insight remains the same. This cause has nothing to do with diet and everything to do with a structural change in the body that basic advice was never designed to fix. The fourth cause circles back to the nervous system, because sometimes the problem isn't the muscle itself or the structure surrounding it, but the nerve signals responsible for telling the rectum that it's actually full. Normally, when stool enters the rectum, nerve endings in the rectal wall sense the pressure and send a signal to the brain, creating the urge to go. But in some people, this signaling becomes dulled or delayed, a condition sometimes described as reduced rectal sensation. When this happens, the rectum can become stretched and filled with stool without the person ever feeling a strong urge to respond. Over time, as the rectum accommodates larger and larger amounts of stool without triggering that signal, it can become significantly enlarged, a condition called megarectum, which makes it even harder for normal contractions to push stool out efficiently. This nerve-related cause is especially common in people with long-term diabetes, since diabetes can damage nerves throughout the body, including the ones responsible for rectal sensation, a complication known as diabetic neuropathy. It's also seen in some spinal cord injuries, in certain neurological conditions like multiple sclerosis or Parkinson's disease, and sometimes simply as a result of chronic, repeated stool withholding that began years earlier, often in childhood. When a person consistently ignores the urge to go, whether from a busy schedule, an aversion to public restrooms, or an old habit formed early in life, the rectum can gradually lose sensitivity to a full sensation altogether, creating a cycle where impaction becomes more and more likely over time. The unsettling part of this cause is that a person may not even feel constipated in the traditional sense. There may be little to no discomfort signaling that something is wrong, right up until the stool becomes so large or firm that it causes pain, bloating, or an inability to pass anything at all. This is one of the clearest examples of why the standard fiber and water approach falls short, because the issue was never about producing the urge to go, it was about the body failing to register that urge to begin with. The fifth and final cause is one of the most overlooked simply because it develops slowly, through repetition, rather than through any single medical event. It's called functional stool withholding, and while it's often associated with children, it happens in adults far more often than people assume. It begins innocently enough, postponing a bowel movement because of an inconvenient moment, an unfamiliar bathroom, a stressful workday, or even lingering pain from a previous hard, difficult stool. But every time the urge is suppressed, the rectal muscles and nerves adapt slightly, becoming a little more tolerant of holding stool in. Over weeks, months, or years, this pattern can retrain the entire system to suppress the urge more and more effectively, to the point where a person may only feel the need to go once every several days, even though their body would naturally need to go far more often. This is sometimes called an acquired megacolon pattern, though it doesn't always reach that clinical extreme. But even a milder version of the same process can be enough to create repeated impaction. What makes this cause particularly hard to catch is that it doesn't feel like a medical condition while it's happening. It feels like a personal habit, something within a person's control, almost a quirk of their schedule, rather than a physiological shift. But the body doesn't distinguish between I'm choosing to wait and I'm training my rectum to stop signaling urgency. Every postponed bowel movement is, in a very real sense, a small lesson taught to the nervous system, and repeated often enough that lesson becomes the new normal. Stool sits longer, water gets reabsorbed by the colon, and by the time a person finally does sit down to go, the stool has often become large, dry, and firm enough that it's genuinely difficult to pass, which then creates a subconscious association between bowel movements and discomfort, reinforcing the exact withholding behavior that caused the problem in the first place. This cycle is especially common in people with a history of anxiety around bathroom use, in individuals who traveled frequently or worked jobs without regular bathroom access, and in anyone who experienced a painful bowel movement at some point and began unconsciously avoiding the sensation that preceded it. It also tends to show up in people who were never taught as children to respond to the urge promptly, so waiting became an ingrained default rather than a conscious choice. The path out of this particular cause usually isn't about fiber or water either, though both can help somewhat. It's about deliberately retraining the body's response, often through scheduled bathroom time, gradual resensitization, and in some cases, working with a specialist on pelvic floor coordination, since long-term withholding frequently overlaps with the muscle miscoordination described earlier. It's a reminder that some of these causes don't operate in isolation. A person can have more than one of these 5 factors working together at the same time, which is part of why the standard advice so often falls short for people dealing with a recurring, stubborn version of this problem. Looking back across all 5 of these, the pattern becomes pretty clear. A muscle that contracts when it should release, a medication working quietly in the background, a pouch redirecting stool away from its normal path, a nerve signal that's gone quiet, a habit that retrained the body over time without anyone realizing it was happening. None of these show up in typical conversations about constipation, and none of them are solved by simply eating more fiber or drinking more water, which is exactly why so many people feel stuck, both literally and figuratively, despite doing what they believe is everything right. Understanding which of these might actually apply is often the real turning point, because it shifts the focus from generic advice to the actual mechanism at play in a specific body. Someone dealing with a coordination issue needs a completely different approach than someone dealing with a medication side effect, and someone with a structural pouch needs something different still from someone whose nervous system has simply stopped signaling urgency the way it used to. Recognizing that there isn't just one explanation for this problem and that the real cause is often hiding somewhere outside of diet altogether is often the first real step toward addressing it properly and toward finally understanding why the usual solutions never seem to work.